Yes, we are going to move on to our next session. It's the Meet the Expert session 5. And we have two speakers today. They're going to speak to us on youth onset type 2 diabetes and awakening epidemic. I would like to invite the first speaker, Dr. Joy George, MD, DNB, DM Endo, FRCP Glasgow, NMAS. He's a senior consultant endocrinologist, director, Endodiab Group of Institutions, India. Over to you, Dr. George.
Thank you very much for the kind introduction, madam. First of all, I would like to thank the Sri Lankan Endocrine Society for inviting me as a faculty for this conference, beautiful conference, well arranged, excellent topics. And then second, I would like to thank Dr. Faria Afsana also for guiding me and giving the necessary suggestions for preparing this session. So our topic for today is divided into two. The first part I'll be dealing with. The topic is youth onset type 2 diabetes, which is an awakening epidemic. And both of us don't have any conflict of interest here. There was a time when juvenile diabetes was considered type 1 diabetes and adult onset diabetes was considered non-insulin dependent and type 2 diabetes. That was 4 decades ago because there was almost a clear-cut division. But time has changed, and now we see a lot of youth coming up with diabetes which could be classified other than type 1 diabetes. So the flow of presentations for today has been divided into four actually. So the first part, we'll be talking about the epidemiology of type 2 diabetes in our part. Then we'll be talking about how the pathogenic differences are there between the youth onset and the adult diabetes, and then going on to the clinical evaluation, which would include the risk assessment, presentation, differential diagnosis, and complication. And finally, madam will talk about the management aspects, and a few cases will be discussed. The clinical profile of type of youth onset diabetes from South India, Chennai, has shown the clear picture of what is emerging and which has already emerged in the Western population and what's emerging in our part of the country. You can see that this was a data from the medical registry of ICMR from the Chennai part, which was published in 2021, which actually shows that after, you can see that's a gradual rise in the incidence of other types of diabetes. Like you can see from 15 to 19, the incidence of secondary diabetes is more than even type 1 diabetes, and also type 2 diabetes is almost as prevalent as type 1 diabetes. And when you go to the age of 20 to 25, you can see that type 1 diabetes becomes a minor component of diabetes incidence. Even internationally, this is a data from the which came in Diabetes Care Study. You can see that the type 2 diabetes in adolescents less than 20 years, it's increasing. You don't have any data from our part of the country, but whatever is available, you can see that the prevalence, it's something from the US data, we can see that it's somewhere in the middle, while the incidence of our part of the Asia, it's actually divided from one end to the other end of the spectrum. But definitely, we can see all around the world the temporal trend of type 2 diabetes in youth. As you can see from this search study, multi-ethnic study, where the ethnicity has also been looked into, it has been seen that the incidence is going up. There's some more faster, the slope is more curved, others slightly lesser. So the incidence is going up. So what about the pathogenesis? Is it just an extension of the adult diabetes? We know that the pathogenesis of diabetes has varied from the triumvirate to the ominous octet, where we think that a particular person with diabetes tend to have 8 pathways which could push him into the diagnosis of diabetes, which in an individual, the contribution of each, the component of the octet may be different. So is it just an extension of adult into the childhood, or is there any difference of youth onset diabetes from the adult onset diabetes? Here what we can look, this study has looked into the insulin resistance and beta cell failure and both. And you can see that in diabetic patients, the first phase of insulin secretion is gone, and also the second phase also is impaired. And you can see that when you look at the obese individuals versus the type 2 diabetic individuals in the youth, it is seen that despite the impairment of both insulin sensitivity and beta cell, both is happening even in youth diabetes, the occurrence of beta cell dysfunction or the degree of beta cell dysfunction is much higher than the adult onset diabetes. Here you can see that even the beta cell sensitivity, glucose sensitivity was around 30 to 65% lower in youth with IGT and type 2 diabetes. And also the incretin effect was much lesser in youth onset type 2 diabetes as compared to the adults. But surprisingly, you can see the incretin levels in youth type 2 diabetes was quite normal as compared to the other non-diabetic population. So it's not actually the incretin level, but it's an incretin effect. The levels are normal, but the effect is poor. Also, one alarming thing that has been come out of the various studies, though not the direct study, it's a comparison, is that from the today's study, it was seen that the rate of loss of beta cell is much faster in youth onset diabetes, that they progress fast in the beta cell damage. So it seems that around 80% of the beta cells are lost by the time of diagnosis. And we know that certain aspects of pathogenesis, which is quite specific for Asia, like we do have a early life undernutrition, and also we tend to be born with a lesser amount of beta cell mass and increased insulin resistance, along with the genetic predisposition, rapid urbanization, and also the excessive early nutritional excess that happens in the postnatal period finally ends up in type 2 diabetes at a high rate of incidence. The multi-level risk factors of youth onset type 2 diabetes involves the social environment, physical environment, compounded by family, individuals, and finally all these things act together to reach to the final culmination that we don't want, that is the type 2 diabetes. When you look at the risk factors from whatever studies are available, we can see that from the US registry, 80% of patients or the youth who were diagnosed diabetic were obese, and additional 10% overweight. That's an overwhelming 90%. Genetic predisposition was seen at least in one affected parent in 50 to 75%. In type 2 diabetes, less than 20 years, 20% risk of one affected family, and 30% if both parents were affected. The incidence of type 2 diabetes, 40% was there in 10 to 14 years, 60% 15 to 19 years, and 30% decrease in insulin sensitivity to puberty. The sex incidence, slightly more in males, but almost there, both. The ethnicity also, there was slight difference, maybe because of the food and lifestyle habits and the cultural differences. The prenatal exposure, like maternal undernutrition, GDM in mother, and low birth weight, and the early childhood weight gain has also been detected as risk factors. Polycystic ovary syndrome is also been described. How to screen for these asymptomatic individuals like children and adolescents? The screening criteria is BMI more than 85 percentile for age and gender. You look into these obese individuals and look at some additional risk criteria like maternal diabetes or GDM during gestation, family history in the first or second degree relative, high ethnicity group, which we all fall in the high ethnicity group, and also look for signs of insulin resistance. And if it is there, then it's said that 10 years or at puberty, whichever is earlier, we should screen those individuals for diabetes. And even if found normal, we should be repeating the screening at an interval of 3 years. And the screening could be either FBS, HbA1c, or both together. And it is said that we will be able to diagnose prediabetes if you do the screening at a much earlier stage. Because the clinical presentation, most of the time, it's asymptomatic in 40% of the individuals. And you often detect this prediabetes stage by high-risk screening and glycosuria on urine analysis. Symptomatic diagnosis is happening in 60% with the typical osmotic symptoms and occurrence of high incidence of vaginal candidiasis and trichia cruris in this population. Diabetic ketoacidosis is not that common. 5% of DKA is type 2 diabetes nowadays. And also it is said that 5 to 12% of type 2 diabetes present with diabetic ketoacidosis, which is quite uncommon because we usually would have learned that type 2 diabetes doesn't come with diabetic ketoacidosis. Even hyperosmolar state, which is mostly said in elderly individuals, is seen in 2% of presentation. Diagnosis is just like the adult criteria. We don't have any separate youth criteria for diagnosis of prediabetes and diabetes. So what to do? We should always give them the lifestyle advice, which is always to be given, and then we should look at multiple risk factors and try to modify the risk factors and repeat screening, and we should try to prevent them from reaching to the range. How to differentiate? That's one important thing. Differentiating type 1 diabetes with type 2 diabetes is quite difficult at times because we know that the prevalence is increasing with both type 1 and type 2 diabetes, and the age of presentation is overlapping a lot. Onset of type 1 diabetes is quite acute while type 2 diabetes could be insidious, while ketosis as diagnosis is more common with type 1 diabetes. But still, as I already mentioned, 5 to 12% in various studies of type 2 diabetes also present with ketosis. Female to male ratio may not give you much idea, but the family history may be overwhelmingly there in 75 to 90% in type 2 diabetes, but only in 10% of patients with type 1. HLA association, ethnicity can all contribute, but we don't usually screen for that. Insulin secretion is decreased definitely in type 1, but it's variable in type 2 diabetes. Sensitivity could be normal in type 1, but it's decreased in type 2. Requirement of insulin is permanent in type 1 diabetic. And weight, there is only, though we say that almost 90% of type 2 diabetic children or youth are overweight, even with the increasing incidence of obesity in our population, 20 to 25% of even type 1 diagnoses are overweight. Acanthosis may be present even in type 1 diagnosis at 12%, and pancreatic antibodies is quite considered diagnostic criteria or is considered confirmatory to the diagnosis of type 1 diabetes. Problems in diagnosis is something that we should understand. It's like 9.8% of clinical type 2 diabetic in youth are antibody positive. Although the clinically type 2 diabetes, almost 10% of them are antibody positive, so we have to reclassify them as type 1 diabetic. But clinically, we would have made a diagnosis of type 2 diabetes. 5 to 12% of type 2 diabetes presents with DKA. That's a problem because we often associate DKA with type 1 diabetes. 20 to 25% of type 1 diabetes are still overweight. 12% of type 1 diabetes has features of insulin resistance like acanthosis. 4.5 to 8% of clinically type 2 are maybe MODY also. That's an important diagnosis to be made because most of you would have heard Dr. Nihal Thomas talking today morning about the other types of diabetes. 10% of type 1 diabetes again has family history. So there's a lot of overlapping which makes things confusing. So it's said that even when you diagnose a type 2 diabetes in youth, we should always reconfirm with insulin autoimmune profile so as to rule out the type 2. Then to confuse things further, there are other types of diabetes which was discussed today morning in the discussions of MODY and other insulin receptor defects and monogenic defects and genetic syndromes which can complicate the situation further. And also we should understand that the first slide which I showed, when we come to the age group of about 10 years, and also when you move up to 20, the incidence of relative incidence of type 1 is coming down, and type 2 and other type of secondary diabetes is even overtaking the incidence of type 1 diabetes. Complications do happen, and the most important part is that complications go on increasing as the years go up, and also the deterioration in glycemic control happen very fast. I've already mentioned that the data shows that the beta cell failure happens much faster in this youth onset diabetic. There are certain baseline characters like baseline A1C, family history, maternal GDM, proinsulin level, C-peptide levels. All those suggest in the initial phase itself on the rapid deterioration in this group. The complication-wise, there was a thought process in a few studies which said that probably the incidence of complication is also more in the youth onset diabetes as compared to adult diabetes. But later on, certain studies in the other complication looking into the registry, they actually say that no, it's not probably more increased. It's more related to the poor glycemic control in that group and also the duration of diabetes that they have to suffer from. Also, when you look at one surprising thing is that when you compare young type 2 diabetes versus a correspondingly aged type 1 diabetic, the incidence of complications are much more in a type 1 diabetic as compared to type 2 diabetes. So the goals of therapy will be dealt by Madam. So summarizing for today's talk, the youth onset type 2 diabetic incidence is alarmingly increasing. It is associated with both beta cell failure and lack of insulin sensitivity, former more than the latter. There is impaired incretin effect without decrease in incretin levels. Beta cell failure progress much more rapidly than in adult type 2. Considerable overlap exists between youth onset type 2 and type 1. Adding to this, the increased incidence of other forms of diabetes, diagnosis is often difficult. Early diagnosis and aggressive management is important as they need to bear the brunt of disease for a longer duration and for the whole lifespan. So I'll be handing over the session and stage to Faria Madam to discuss on how to manage this youth onset diabetes. Thank you. Thank you very much.
Thank you very much, Dr. George, for that very informative and wonderful presentation. Due to time constraints, we are unable to allow any questions. So we'll thank him, show our appreciation in the usual way.
Our next speaker is Dr. Faria Afsana. She's an Assistant Professor and Consultant Endocrinologist, Department of Endocrinology, BIRDEM General Hospital, Dhaka, Bangladesh. Over to you, Madam.
Thank you, respected chairperson and honored audience. It is a great pleasure for me here, and thanks to the organizer for inviting me in this beautiful conference. And after the beautiful talk of Dr. Joe, and there is very little thing to tell about, and he clearly described the clinical features, types, and the pathophysiology, and how to differentiate different types of diabetes. So let me talk about few words about management of youth onset type 2 diabetes. And the goals of therapy, as mentioned by him, to maintain near normal glycemia, improve the insulin sensitivity and insulin secretion, identify and treat the comorbidities, and to prevent the complications. But there are some challenges in managing children and adolescents because, as mentioned by the previous speaker, type 2 diabetes has a more aggressive course in children, and the pharmacological treatment is very much limited, and there is a more decline, the rapid decline in the beta cell function and high treatment failure, and there is a more aggressive diabetes-related complication than that of the type 1 diabetes because obesity is a factor which initiates these complications. So what should be the target? And the most important target is the weight loss, as most of the patients, the 80% of the patients are obese. And of course, the target should be individualized, and if you concern about the HbA1c, it should be less than 6.5% by NICE guideline, and in some patients having shorter duration of diabetes, lesser degree of beta cell dysfunction, and have significant weight improvement in those patients, it may be less than 7%. A higher target may be considered for patients who develop frequent hypoglycemia. And as that of adult, this is the basic goals of care, and in the center, the patient's empowerment is very much important. And for children and adolescents with type 2 diabetes, in this center, along with the patients, there is the parents, the family members, sometimes the school teachers, and the caregivers. So all must be educated about the management of diabetes of this particular young adult. And the first step is lifestyle modification. The diet should be proper, having a 50% carbohydrate and 25% protein and 25% fat with less than 7% saturated fat. And the important thing is lifestyle modification is physical activity. They must increase the total physical activity time, decrease the screen time, and decrease the total body fat gradually, which may increase the insulin resistance and thus improve the glycemic status even without any medications. So what is the pharmacological treatment for this particular youth onset type 2 diabetes patients? Still now, only the 3 drugs are recommended and for these patients by US FDA and European medicine agencies. But the American Diabetic Association included only metformin and insulin for the treatment of these patients. And GLP-1 analogs are recommended by US FDA and EMA. And this is the guideline for managing these patients according to the HbA1c level. When the new onset diabetes and overweight youth initiate the lifestyle management and diabetes education. After that, after a period of 4 to 6 weeks, if the HbA1c is less than 8.5% and there is no ketonuria or acidosis, they can start metformin and gradually increasing the dose. If the baseline HbA1c is more than 8.5% and there is no features of ketoacidosis, then either basal insulin or intensification of the metformin can be given. And if the patient has acidosis or diabetic ketoacidosis or HONC at the time of diagnosis, then the management should be as that of the diabetic ketoacidosis and insulin should be continued. But while having the clean-cut features of type 2 diabetes, the pancreatic autoantibodies must be checked because there are possibility to overlap of type 1 and type 2 diabetes. So individual drugs, the metformin, how to start? 500 milligram once daily for 1 to 2 weeks, then follow up gradually for a 3 to 4 weeks period, and the target final dose may be 2 gram per day maximum dose. And regarding the insulin is indicated in type 2 diabetes when the patients are metabolically unstable, having HbA1c more than 8.6%. The diagnosis is unclear, either it is a type 1 or type 2, so better to go with insulin, then establish the diagnosis, then we can shift to oral agents if required, if it is type 2. And if ketoacidosis or acidosis is present and not achieving the HbA1c target within 4 months of metformin monotherapy, then insulin should be the treatment of choice. What about the third agent? As recommended by or approved by FDA, GLP-1 agonist, and as weight gain is a particular concern for these obese type 2 young patients, the GLP-1 receptors have a promising effect for them. And they are recommended because there are several studies with liraglutide to be safe and effective for these particular patients. And there is no scope of use of sulfonylurea for these patients, and most of the pediatric societies do not recommend sulfonylurea for these young patients. There are several drugs who are ongoing clinical trials, including the tirzepatide, the combined GLP-1 and GLP-2 receptor agonist, semaglutide, artogliflozin, canagliflozin, and dapagliflozin, along with the DPP-4 inhibitor linagliptin, and the trials are ongoing, the phase 3 trials, and we are waiting for the results to see about their use in the young onset type 2 diabetes. Another option mentioned in few guidelines about the bariatric surgery, because most of the patients are obese here, and if they have the BMI having 35 kg per meter square and uncontrolled hyperglycemia or serious comorbidities or develop complications in spite of treatment with metformin and insulin, then bariatric surgery may be an option, but it should be very careful that the experienced surgeon should be there, and there is a multidisciplinary team approach, including the surgeon, endocrinologist, nutritionist, behavioral health specialist, and nurse. And this is about the treatment of young onset type 2 diabetes. Let us see a few cases. This is a picture of an 11-year-old girl gaining weight and having increased appetite, getting tired very easily, no symptoms of polyuria or polydipsia, and there is a positive family history of diabetes, and the parents are very much concerned about her weight gain. And her obesity is BMI having 28.8 kg per meter square, that is more than 95th percentile, having severe acanthosis nigricans. And investigation shows a random blood sugar of 10.8 millimole, having an HbA1c 6.9%. She had elevated liver enzyme, C-peptide, and insulin level. And fatty liver was found on ultrasonogram, and the antibodies are negative. So screening recommendation, as shown by previous speaker, these patients, though they are very much concerned about the obesity, but as she has several indications for screening for diabetes was done. And the common characteristics of type 2 diabetes as present in this particular case: adolescence, before puberty, female gender, and the low socioeconomic group, positive family history of type 2 diabetes, overweight and obese, and these characteristics made her a unique candidate for screening for type 2 diabetes. So it is shown by the previous speaker about the difference between the type 1 and type 2 diabetes, and according to this criteria, she is a type 2 diabetic patient having developed in early age, and metformin was given, and she has been followed up regularly. And after 1 year, she had good glycemic control, but no reduction of weight, as she is not motivated about the lifestyle modification. And initial investigation revealed no complications. So she has undergone extensive counseling and health education classes, and screening of the complication was advised regularly. Next, move on to the second case. A type 1 diabetic girl at her 16 year of age reported with weight gain and acanthosis nigricans, and she was diagnosed as type 1 diabetes at her 13 years of age. And she was second of 4 siblings of a non-diabetic parents, but had one sister who had type 1 diabetes, and there was no history of clinical evidence suggestive of polycystic ovary syndrome, and her menstrual cycle is regular. So she was type 1 diabetes for 3 years, and now presented with weight gain and acanthosis nigricans. During diagnosis, she was actually presented with ketonuria, antibodies were positive, and C-peptide was low, and BMI was 23.8 kg per meter square with no markers of insulin resistance. Antithyroid antibodies was negative, and she was normotensive with normal lipid profile, and started insulin as that of type 1 diabetes and discharged from the hospital. And if we compare the initial presentation and 3 years post-diagnosis, acanthosis nigricans was absent but now present. BMI was is high now, and the C-peptide was low and also low now also. And the antibodies was positive, which is still positive in a low titer. And anti-thyroid antibodies are still negative, HbA1c is a little raised, and the treatment was previously on lifestyle modification and insulin. As there is an increase in the features of insulin resistance, metformin was started. And what is her diagnosis? Actually, there are new features that she diagnosed as type 2 diabetes now, and all the features are like that of type 2 diabetes, but previously she was on type 1 diabetes. So is it a double diabetes? Moreover, she was counseled for lifestyle modification, and metformin was started, and within a period of 2 months after starting metformin, the insulin requirement was decreased, and the dose requirement was 48 units per day, and her glycemic profiles also increased. So what is double diabetes? Or another name is hybrid diabetes. It is a new variant increasing in prevalence due to increased obesity. The patients are characterized by presence of type 1 diabetes both and the insulin resistance feature. And the occurrence can either develop on a background of type 1 diabetes with abnormal increase in weight and physiological growth spurt. And sometimes it is thought that due to the insulin, there is a gradual increase in the weight gain. And it has a possible increase of the cardiovascular risk due to increase in the features of insulin resistance. And this is the other name is hybrid diabetes, which has a genetic predisposition, and there is an increased metabolic stress and environmental factors that increases the features of insulin resistance and failure to insulin secretion, as well as both the features, the failure of insulin secretion and the resistance makes the condition dreadful. And let's move on the last case, a 22-year male with BMI 16.7 kg per meter squared, diagnosed as type 1 diabetes, 4 years prior in the local hospital and discharged with subcutaneous insulin. He was a normal birth weight, and his father had a history of diabetes and insulin treatment, and his blood glucose showed great variability with hypo and hyperglycemic episodes. And regarding the his medical history, he was adolescent at onset, weight loss, and the parents has family history of diabetes and poor glucose control and under intensive insulin treatment. Gradually, her insulin requirement was decreased, and she was started and well managed with glimepiride 2 mg, and HbA1c was target, and gradually due to frequent hypoglycemia, glimepiride is also decreased. So what is the type of diabetes for this particular patients? It may be a case of type 1 diabetes having honeymoon phase, now not requiring insulin, or type 2 diabetes in young, that is the hybrid diabetes type, or a monogenic diabetes. So what is the monogenic diabetes? The maturity onset diabetes in young. This is a heterogeneous group of disorder with autosomal dominant inheritance and mostly with normal BMI and usually diagnosed under 25 years of age. And the MODY has different varieties having the genetic link, and the MODY2 variety is the most common variety, which is very close to that of the type 2 diabetes. So what is the difference between this MODY and the type 2 diabetes? Age of onset. Usually the MODY occurs in childhood and adolescence and young adulthood and has a familial generational effect, though type 2 diabetes occur in adult, but in nowadays the type 2 diabetes is also occurring in youth. So there is a very close relation with MODY and type 2 diabetes. And usually the multi-generational is MODY, and it may be familial in type 2 diabetes. In body habitus, the MODY patients are non-obese, but the type 2 diabetic patients are usually obese, having features of insulin resistance, and other features of metabolic syndrome are usually present. So if I summarize, youth onset type 2 diabetes is relatively recent public health problem resulting in increase in obesity in epidemic countries. And while sharing a similar pathophysiology with adult onset diabetes, type 2 diabetes in youth has unique characteristics of rapid progression and rapid development of complications. And early detection and treatment are crucial to prevent serious comorbidities and complications, as it is more prevalent among these young patients. Thank you all for patience hearing.
Thank you, Dr. Faria Afsana, for the wonderful presentation. On behalf of SLC, I would like to thank both speakers for the very informative talk. We'll conclude the symposium. Because of the time constraint, we don't have time to discuss regarding this topic. You may discuss regarding the tea time. Thank you.